thought I'd just try and do is put some environmental factors in place first that post-election haven't changed yet. Probably explain why reforms fail and why this reform is failing, and some of the unintended consequences that's happening in primary care to meet some of the what is failing with CCG's engagement with general practice. Is that right? Okay, so just to put into context, I'm speaking from both the experience of being a GP. I'm studying clinical practice for 26 years. I've done 2 stints with the Department of Health, ministerial advice, policy development. I was the clinical lead for developing clinical commissioning. It was the narrative, the function of clinical commissioning, not the form, even though at the moment we're just really focused on the structures. And in fact, in the 26 years I've been a GP, whenever we attempt reform, and there's been several attempts to reform the internal market created in 1990, we end up just restructuring, and I don't think we transform anything. In fact, I'm sick of hearing the word transform, because at the moment we are still in a process where we're looking at structures, form rather than function. So I look from a perspective of both clinician in general practice, policy advisor. I also chair a pharmacy company, and maybe we'll get a chance to debate about why that might be a focus for the industry in the future as not a new provider, but a provider who is going to be taking on some of the roles that historically were from general practice. It's not quite the panacea that general practice is going to be freed up by just using the pharmacies, but if you look at international markets where the state doesn't pay for healthcare, as in the UK, if the payer is the patient, they don't want a GP or a diagnostic, they want a treatment. So their pathway is to the pharmacy, where they get first port of call, not a generalist in the community. And whether we've got time to talk about some of the international work I'm doing at developing primary care systems. And finally, just to give a balance, so it's not just focused, I am a non-exec director of a specialised trust. It's a cancer trust in the northwest. Gosh, the board there, we can run rings around the area team. It's frightening about the skills of the provider and the boards compared to the skills of the commissioner, which is frankly rudimentary, whether we've got time for that as well. So just to put into context, but why reforms fail and where we are in this environment. And it's interesting, already we're talking about, in this meeting, CCGs and GPs. Failure. They were supposed to be synonymous, one and the same. So the very fact we're talking about how do we get engagement between GPs and CCGs highlights the failure that is happening at the moment. And the disquiet, whilst we've got about maybe 2,000 to 3,000 general practitioners in England engaged in their GP, working as positional leaders, trying to do a good job in their CCGs, we've got about 30,000 plus GPs who are disconnected, disenfranchised, disinterested, and doing something else. The unintended consequences of them refocusing on where inherently we all are, designed as providers. So I know David's going to be talking a little bit later about the evolution of federations, but there does seem to be more energy in the development of new provider forms, nothing that was in policy, by a much bigger majority of general practitioners and indeed pharmacists than we've got engaged in being commissioners who, again, don't quite understand what their role is. So the reasons why we are struggling with transforming the NHS at the moment, and we are looking at different models of provision, is that there's a consistency from the creation of the internal market. I was an enthusiastic, I'm going to say the F word now, I was an enthusiastic fund holder, which was the first vehicle that tried to manage efficiency in that internal market created by the Thatcher government. And we've had lots of vehicles since then, and I've jumped on, I became sort of a first wave junkie, where there was PCGs, practice-based commissioning, PMS, all the acronyms. They were just new vehicles to try and improve efficiency and focus what Lansley tried to do, the alignment of clinical thinking with the resources that are deployed as a result of it. And CCGs haven't got that. So the important thing about the reforms was always to try and change the culture in the system, the behaviours and where resources are deployed. And I still suggest that most of the money that is spent in the NHS starts at the interface between clinician and patient. Whether that's the district nurse putting a dressing on a leg, or a GP deciding to make a referral or write a prescription, or the consultant body in hospital doing something in outpatients. That interaction is interesting where patients describe, if you look at patient information, quality is described at that interface. If that interface goes wrong, then it doesn't matter what the rest of the structures are like, whether they're clean and tidy. If the interaction where resources are deployed and the decisions made isn't right, then the rest of the system fails. And we're not changing behaviour of that interface, because most clinicians, if it's a community nurse, they've got no idea what's happening in commissioning. If it's a general practitioner, we've got 30,000 plus who aren't really interested and are still making decisions just on the best interest of the patients. We all should do that, but they're not aligning their thinking at the time of writing the prescription. Is this the most cost-effective way, evidence-based, involving the patient and also in the best interest of the patient? They're just saying, whatever I think is appropriate, I'm going to prescribe or make the referral, because we haven't got the alignment correctly. What we were supposed to do, and what the Health and Social Care Act, if you boiled it down, what the legislation was for, well, there was two things. One was to align clinical decision making with the resources that we deployed and making law. So when I write a prescription, I'm supposed to be legally accountable for the resources. But I'll come to why reforms fail. I am legally accountable through the CCG, but am I conscious of it? No. So behavioural change hasn't occurred where we have the massive collective of the clinical community. This is what clinical commissioning was supposed to do. Start to make decisions with their patients in a way that not only produces best evidence practice, but understands the resources that are deployed. And we've got a remote organisation trying to do that. It's a PCT, they're interchangeable. I'll come to it. So behavioural change is what we're all trying to do, so that it is the remarkable events where one GP today in surgery, we've maybe got 20,000 GPs consulting as I'm speaking, making decisions with their patients about referrals or a prescription. If you just do one remarkable event, if 20,000 GPs made one remarkable event that saved £10 every day of the week, you'd start to address the billions of pounds efficiency gains that we're looking in the NHS. Not one big piece of heavy lifting that moves the care of patients with diabetes from here to here. It's about the remarkable behavioural changes. We haven't got that right, and when we've not got it right, reforms fail. The closest we had was probably fund holding. Lots of problems with it, but when the budget was with the referrer and the prescriber, we saw dramatic changes. The second is leadership. And we talk an awful lot about leadership, but we always usually end up with positional leaderships. CCGs have beauty contests to see who's going to be elected to a particular position. They then have selection processes, put people in place. Then you have a GP who you'll try and interact with. If you, let's go back to diabetes, your company, if you've got diabetes, you'll try and find the diabetes lead for the CCG. And somehow that one individual GP is going to change the minds of 200 clinicians in their area because you've interacted and they've said something. If you know about general practitioners, we've got 35,000 GPs. If you ask their opinion, you have 36,000 opinions. The analogy, which I sometimes find difficulty about, herding cats and getting eagles to fly in formation, it's fairly consistent. Most general practitioners came through a process where I still interview at Liverpool Medical School. We've got a cohort of people who inherently were achievers. They've gone through medical school, they want to be at the top of the class. They're not wanting to be herded. So if we don't get the individual changing their behaviour, so leadership becomes a style of practice. How do you change your practice as an individual and a small team in your general practice and lead the service that you provide differently. Not have positional leaderships. What are we doing in CCGs? A remote organisation, positional leaders. It is a common theme, the work I did with the Department of Health about the themes that make reforms fail. So we're not changing behaviour, we're not changing leadership, and then the final is the tools to do the job. If I haven't got a budget, I am not going to make changes. And at the end of fund holding, I'm not wishing that we have that back, I want to review the best of the forms that try to manage the internal market and produce the efficiency of the bits that really worked. But at the end of fund holding, he was latterly the National Clinical Director for Primary Care, David Conitoni, is now retired. We coined the phrase, a GP with a budget is worth 10 on a committee. And what we've got now, we've got GPs on committee, but a GP with a budget makes the same decisions as the budgets they manage in their GMS or PMS contract. So, for example, in our health service, we have this strange situation where, say, Artillery Group practice in Wallasey, which I'm a senior partner, say has £1 million turnover for the 6,000 residents who choose to register with my practice, and that £1 million is managed really efficiently. I'm an independent contractor, I'm self-employed, I'm the employer of the staff, I manage the estates. So, manage the estate, we manage the utilities. So in a meeting where my practice manager was, I said, so within general practice, when we've got a fairly fixed income, we manage our efficiency so that my manager will know the price of paperclips, because on a fixed income, the profit of the organisation, what pays me, my partners, is entirely dependent on how we manage our expenses. And we don't have an income crisis and then sack the nurse. We look at the efficiencies of the overheads. So she knows the price of paperclips. And she was in the audience and she went, no, I don't. So I remember saying, Sue, just work with me here. It's an analogy. So she went, why would I buy paperclips when they come through the letterbox every morning? Now, it's not about knowing the price of paperclips, but that is the efficiency that the good general practice manages. Can we import that efficiency into the £7 million that my practice utilises through our referral activity, our prescribing activity, or the activity we don't really get involved in anymore, the out of hours, the urgent care? Because if we imported that mindset, which what clinical commissioning was meant to do, and there is a reason for the story, because I'm going to say what might be happening in the future, is that we would make the efficiency gains that would make the 8 billion requirement pretty easy. Some of the, again, the work I did in the Department of Health about the waste in the system. So as a non-exec director of a hospital, I go into the hospital, my hospital at 6 o'clock at night, and there's huge areas called corridors with no patients in, the lights are on, there's nothing happening, and the heating's on. I'm walking down looking for the light switch, because in my practice, when nobody moves, the lights all go out. So it must be interesting, because I'm paying for it. In the hospital, the overheads, and it's not just about the utilities, but the consumables, the disposables, the workforce, and the workforce planning, which we've got all on, means that we've got incredible amount of waste, duplication of service, and inefficiency, at least at 20%. Well, I've just seen from the slide before, 20% waste is £20 billion of taxpayers' money. Now, if we just improve that efficiency by getting that alignment between clinical decision-making and resource utilisation, that's 20 billion for a start. Before we even start to manage budgets, which everyone does in their own household, general practices do, primary care across the system, who are independent contractors do as well. So we need to import that, and that's why we are, again, with the reforms that were well meant. I wasn't advised to Andrew Lansley. I do feel a bit sorry for him. Of course, he's not an MP anymore. But he did spend 6.5 years listening to clinicians and putting in place some legislation that tried to align that clinical decision with the resource utilisation and look at better outcomes or measurement of outcomes, the 5 domains. That was what the legislation was about, making sure we had legislation that proved the outcomes for the investment. But unfortunately, and this is why I get to co-commissioning, Tim, whether you invest a lot of time, energy and resource in CCGs, because I think I can guarantee you one thing by the end of this current Parliament, CCGs won't exist. if we've got any organisational memory, if we've got any reflection of, and it's usually history does start to dictate what will happen in the future, the organisational forms will change. We'll still have an ambulance, we'll still have a pharmacy, we'll still have my general practice, we'll still have hospitals, we'll still have clinicians in the system, we'll still have that NHS in 5 years' time. We might have a different payer, but we won't have the structures. If it tells us anything, nothing has survived. I was vice chair of a health authority, then I was a PCG chair, and I've been a practice-based commissioning organisation with an LLP. And so there's only one thing for certain, that my general practice has survived all through that, and the practice nurse and the management, none of the structures that are created. So when we put lots of slides about the structural form, and lots of people, like this audience, want to know about the structural form, I'd say you're wasting a lot of time and energy in that, as opposed to thinking about who the customer is, what the market is like, and where to focus the best efforts of your industry to align it with the new world. And finally, just on that history, I remember helping to write Sir David Nicholson. What about his speech in 2010 at the NHS Confed conference? Anyone went to Liverpool a few weeks ago, Confed? I'll see you there as well. You'll probably hear the same stuff as well. But he said, and he was a bit bruised, of course, as when he in his younger days was a member of the Communist Party, I'm not kidding, working with a right-wing Secretary of State, who then brings in legislation that's going to lose 40% of NHS management, his family. He had to say something on stage that was the abolition of SHAs and PCTs was going to have some bright new future. He had great difficulty, but what he did say is if we recreate, through this reform, if we create what we had, if we don't do something transformational, then it will be misappropriation of funds, and there should be a public outcry about that because it will be a scandal. They were his exact words. Co-commissioning finally describes that scandal. Because if anyone can describe to me, if co-commissioning takes on the contracting of primary care, starting with general practice and then the other 3 primary care contractors, optometry, pharmacy and dental services, and takes on more, because Simon Stevens wants to push all the commissioning out, he's not a commissioner, he wants to just run the service. But if we look at more of the co-commissioning, can somebody tell me the difference between a PCT and a CCG? The only thing that the PCTs did, but they removed their provider function of community services long before the 2010 white paper. But they are identical. As a taxpayer, I feel quite indignant about that. It is a scandal, co-commissioning, my words, but the process by which we are recreating the PCT, 40% of NHS managers lost their job, and we lost those really skilled managers who might have been in the same position as some of the CCG accountable officers 10 years ago and may have learned on the hoof, but by the end of the 10 years of PCTs, we had some skilled managers. And as a clinician, sometimes I grated against them, we didn't see eye to eye, but I'd much prefer those managers in place than some of the CCG managers, because often what we've got now is the middle management of CCGs managing a far more complex system and an accountability arrangement for local services that are probably past what CCGs were, PCTs, it's interchangeable. So we're in a worrying situation. So what's happened is the unintended consequences where the market is changing. I'm president of an organisation called the National Association of Primary Care. That was created for fund holding association. It's a membership organisation, not for profit, but it does try to influence policy, and I still have some work influencing policy from the other side now, not from while I'm being in the Department of Health. We've just created something called the National Association of Provider Organisations. That now has 71 GP federations covering 11 million of the population. It's England and Northern Ireland because NAPC. That is where the energy is, the enthusiasm within that subset of provider organisations, albeit frustration about organisational skills, and this is where the industry might be helping, is where general practice enthusiasm is flourishing. Just as we've got some fixed people in their CCG roles who are trying to do a good job, but they're not creating the enthusiasm of the majority of not only GPs, because we've got 2 pharmacy confederations, one in Leicester that's got about 70 community pharmacies working together and have now got contracts that used to be provided by general practice. Now that is starting to get the attention of Simon Stevens, and how many times I've got a detail 5 minutes ago.
Yeah, give it a few more minutes, and you're doing well.
Okay, well thanks for that. Gold star from teaching. So the federation movement, and we'll probably have to talk about the detail of that, is certainly sparking an interest which is getting the attention of Simon Stevens. Because within the 5-year forward view, and I deliberately have not talked about the documents that anyone can read online and you can interpret, the 5-year forward view you've probably digested. With great respect, it wasn't written by all those people, it was written by Simon Stevens, let's be quite clear, and Monitor and TDA will put the stamp on it. It's Simon Stevens' outlook, and the subtext for it is he wants to create something in the UK which you recognised in North America, where he spent 10 years. The Accountable Care Organisation. Come across that? The Federation movement, which is outstripping his vanguards of new provider models, and I think we can largely forget community hospital provider models that more or less ditch that. You can largely forget the nursing home that's going to create some new provision. So there's only 2. There's the PACS, the acute and primary care vertical integration around urgent care, and the multi-specialty community provider, MCPs. It was all about MCP, wasn't it? Now showing as a pig. But anyway, MCPs, which have got, those 2 have got these 20 plus vanguards, which again there is some worry about, are they going to make any difference? They're supposed to have an impact soon. If you look at the vanguards, they are the usual suspects. They've already been doing stuff for ages. There's a great one in Winston. I know the guy at the GP I mentioned, but he's been doing what he's been doing since front-loading days. So he's going to be successful in what he's doing, he's just using a different vehicle to do, so the vanguard model. So just to finish on at this point then, is that I had a meeting, dropping with Simon Stevens about 6 weeks ago. I think if I tell you this, I've got to kill you all, but anyway, this is partly in confidence, but I'm saying it anyway. But it was a discussion which was jaw-dropping. I've been in many meetings with ministers and senior officials. It is probably simply the most jaw-dropping meeting I've ever had. Do you want to know? And at that point I'll finish.
That's our next forum.
We're talking about the evolving models and how to accelerate them and how to engage more clinicians. And I was on my usual stand of, you've got to give the tools to do the job. We've got massive amounts of data in the NHS, but not necessarily the right information. A lot of the information is locked in primary care systems. We've got clinicians who want to make change, but they haven't got the tools to do the job. We want to change leadership in smaller units. And the 5-year forward view made it clear that the MCPs were not meant to be these huge organisations, and CCGs were not meant to cover huge populations. They were supposed to be small, mobile, inclusive. My first CCG, and I was at odds with Barbara Hakin here because she just wanted to recreate PCTs, and she has. Mine was to have a CCG no bigger than covering 50,000 population. So to do the tools, to have inclusive, to have a model which mixed personalisation, not losing the personalisation of care at the small general practice, but looking at population health, and population health through the registered list has always been my sort of thesis, is the population in the NHS is described by registration with general practice. That's how, I'm not being precious about general practice, I'm not precious whether we call it general practice in the future, but you access the NHS by registering with your general practice. If that changes, then fine. But if you go to A&E and you're not registered with general practice, you should be turned away, because you're not registered for NHS treatment. So the registered list is the population. The amalgamation of that up to a size where you can start to do population health analysis of the need of a population, then do some workforce modelling and supply a service against that need. Sounds like clinical commissioning. The contract stuff, then some, pointy-headed people, those experts in management can do the contract stuff. But that balance between population health and personalised care has got to have a size, I don't know what's quite right, but if it gets past 50,000 it gets too big. Simon Stevens wants that. He wanted Vanguard to be that 25 to 50,000 population coverage. The geography was less important than the affinity, so the affinity between groups, maybe general practices, to deliver a programme which started to take control of budgets and be accountable through a total capitation process. So you might have a few practices, and I don't want to steal David Sunday about some of what he's doing, but say you get 3 or 4 practices together, like-minded, want to work together, they've got a population base of say 30 to 40,000, give them a total capitated budget, not only for their GMS, PMS provision, but the work that they do on behalf of that population in terms of extra provision, referrals, the stuff that CCG sort of manage, not the specialised stuff yet, because there are some risks, I won't have time to go into that, but give them a total capitated budget and then challenge them to really focus on the make or buy decisions within that organisation. And the idea of clinical commissioning from Andrew's land reforms was make more, buy less. Not get a different organisation to buy differently, it was to the providers, if they were accountable for the budget, make more, i.e. extend the management of patients so that you can deliver services within the community, out of hospital, and not make referrals to the hospital where it becomes very expensive. Particularly on the low-tech, low-complex stuff. The Accountable Care Organisation in North America is described as a unit in a community with a registered population, with a budget making make or buy decisions. We're almost there if we get general practice working collectively. All of them are involved in making decisions on make or buy. There's some workforce issues as well around that, because if you then start to analyse the need of a population, if you talk to a GP in surgery today and say, how many patients coming to see you needed the skills of a community physician and the training of a GP, there'll be a variable response. It will not be 100%. 100% need some care. Some will say 80% need to see the GP. Me, I might say 20%. They need to see somebody, but my skills in general practice are not best deployed by the majority of people I see. But they need a skill set that needs to be accessible, integrated, immediately available. Whether that be physiotherapy, chiropody, third sector, social care. So if you get that organisation around a population base and give them a budget, we could call it the primary care home, an accountable care organisation, but that would work. That would focus all the aspects of the Health and Social Care Act in terms of behavioural change. Simon Stevens said, write me the paper, do it, put up or shut up. We've written a paper, it's been accepted. I've said that sort of organisation we're talking about, 25, 30,000 population, might need about 30 million plus of real cash to manage independently and put possibly their own income at risk as a result of it. He said, I'm not blinking. You describe it, I'll make sure it's funded. This is not too different. Sam Jones, have you come across Sam Jones, who's leading the new models of care? She was in the room and she went, because, but the principles of what the Health and Social Care Act, what the 5-year forward review was trying to do, the models of care, and the fact that most clinicians are still looking to create new provider models, i.e. the federations, is something that our chief executive recognises and wants to promote. Because we are at, well, I remember Alan Milburn in 2000. We were around 2000, the 10-year plan for the NHS with the Labour government. He said, the NHS is drinking at the last chance saloon. Even then. But I guess we always have this leading time to falling over the fiscal cliff. But we are at the last chance to have a sustainable NHS that is fully state funded. With it by mid-term, there'll be some debates around that.